I'd like to ask Vipul Aggrawal, who's one of the interventional endoscopists who's working with us, who's doing the newer ways of managing weight through endoscopic techniques, to talk about what endoscopy and endoscopic procedures plays in managing weight loss. Should I answer this one? Yeah.
Thanks, Viraj. Good evening, everyone, and thanks for coming here tonight for this important seminar. I'm going to change tact a little bit and move on to basically endoscopic bariatric therapies, and I call it the elephant in the room, and I'll try and explain why in a bit. Trying to move forward. Okay. So I'm going to try and talk a little bit about the background of obesity, which the majority of which has been covered by Viraj and Shamini quite elegantly, so I won't have to focus much on that. And then talk a bit more about the currently available endoscopic options for obesity, and only enumerate the future therapies in the interest of time. We looked at a lot of data in terms of how big an epidemic or how big a problem obesity is. So this is another way of looking at it. This website called Worldometers updates stats every second during the day. And if you look at it, there's about more than 800 million people who are undernourished, but about 1.6 billion people who are overweight in this world, and about 700 million people who are obese. In the US, they spend about more than $350 million a day with obesity-related diseases. So obviously, the same theme applies, that it is a big epidemic and it is a problem. And this slide just represents the increase in obesity or prevalence of obesity in adults. And since 1980, Australia has about an 81% increase in obesity rates, only behind New Zealand for that matter, but certainly ahead of the rest of the world. We've talked about this. Obesity is not a static disease. It impacts all sorts of, various organ systems and quality of life, and therefore management of obesity is critical. Shamini covered the standard therapy of diet and exercise, some proprietary weight loss programs, pharmacotherapy. They're all effective, but you have to agree that they're modest in their efficacy, and long-term data in terms of safety and the weight loss, maintaining the weight loss is not there. So I suppose other adjunctive therapies are required. The most thus far, bariatric surgery has probably been the most prevalent one. I'm not going to talk much about that because our next speaker, Dr. Garrett Smith, is going to tell us all about that. But essentially, we know that bariatric surgery works. It causes a significant amount of excess weight loss, somewhere in the range of 50 to 70% excess weight loss in about a year, and does improve other medical comorbidities. But there may be some things to consider, which are the associated cost, possibly some morbidity. And it is probably best, although Garrett might think differently, of patients who have a BMI of greater than 40, or patients with BMI between 35 and 40 who have significant comorbidities. But we also know that a good majority of our patients will have a BMI between 30 and 35, and we need to consider what might be the best option for them, in addition to standard therapy of exercise, diet, and pharmacotherapy. The other issue which kind of needs addressing is probably less than 1% of patients who actually fit the criteria for bariatric surgery undergo the surgery. Once again highlights work that needs to be done in that area. So bariatric endoscopic interventions, I said elephant in the room because it's, relatively speaking, it's a much newer concept in terms of the various procedures that are available. And also there's been some initial skepticism. And it's only after 2011 that a lot of these procedures have been adopted in practice with the coming together of the American Society of Gastroenterology and the American Bariatric and Metabolic Surgery Association. And for it to, why do we think that endoscopic approaches may work? They're probably going to be less invasive. They may be more cost effective, although that remains to be determined in long-term clinical data. They probably have a lower risk. can be done as a day-only procedure, and in a cohort of patients may be used as a bridge to surgery. When we look at the various procedures, you could look at them different ways. You could look at them as endoscopic bariatric therapies based on the site or organ in the body that's intervened. So you can have gastric interventions or small bowel interventions. And the other way of looking at them is by the mechanism of action. So you have space-occupying lesions, which primarily consist of intragastric balloons. You could have gastric restrictions with endoscopic sleeve gastroplasty, or the less commonly used primary obesity surgery endoluminal process. There's an aspiration therapy that I'll touch on briefly, or the malabsorptive therapies, which are primarily in the small bowel. So what are the currently available options? So the FDA-approved options are the intragastric Botox injection, intragastric balloons, and there's a few of them around. There's the endoscopic sleeve gastroplasty and the aspiration therapy. I'm only going to have one slide on Botox, because although it's technically simple to do, you can repeat it, and it's very safe. The duration of effect probably only lasts about 6 months, and at best you get a very modest weight loss effect of about 5 to 8 kilograms. So I think Botox, like for other indications, is probably more of a cosmetic thing rather than actually making any significant clinical impact. Intragastric balloons, there's at least 3 or 4 on the market, and they've been around for a while. I think they introduced it in the early 2000s, but they've been continually improved in terms of the materials that they use to make them and their efficacy. So they're generally placed endoscopically and are filled with fluid, although there's one variety which is ingested by the patient and is filled with gas. But like I said, for the purpose of the talk today and the interest of time, I'm going to focus on one of them, which is the Obera intragastric balloon. It's made of a silicone elastomer, and like I said, it's inserted under endoscopic control into the fundus of the stomach. Once inside the stomach, you inject it with about 450 to 700 mils of saline and add methylene blue. The methylene blue is added as a safety marker, so if there's a leakage, the patient's urine turns green, so you know that there's a problem with the balloon, and you've got to probably go back in and have a look. The balloon is left in place for about 6 months at most, and it needs to be removed at the 6-month period. The first study published was sort of in 2005, which showed an excess weight loss of about 33% in about 2,500 patients, with an improvement in both diabetes and hypertension. So obviously a significant improvement in terms of what was available prior to that. I'll try and run a couple of videos and I'll move them along a bit quickly. So this is a video of how an intragastric balloon is inserted. You should always do a check gastroscopy prior to inserting the balloon, making sure that there's no obvious contraindication for the balloon, to use the balloon as a weight loss therapy. Once that has been done, so that is the rolled up balloon, which is inserted under direct endoscopic vision. That's the cricopharynx vocal cords on the left. The balloon is passed through the esophagus and then into the stomach, into the fundus area. I'll move that forward a little bit, and as you see, that's the saline being instilled into the balloon. And keep moving it forward till you end up with a final volume of about 500 to 600 mils. And there is a sample balloon at the back, but this is what it would look like inside. Okay. So that's what the balloon looks like inside the stomach. The extraction of the balloon also is done endoscopically, and is somewhat a little bit more challenging, where you go back in, you puncture the balloon with a needle, and then you connect that to a suction, wall suction, and aspirate all of that fluid which has been left in there. And I'll just again briefly show you what that involves. You suck it all out, and you're left with this dark, mucky looking thing. God knows I'm eating right now, and then you pull it out with either a snare or a rat tooth forceps. So that's the balloon. Again, I won't talk a lot in detail regarding the studies, but it's always good to look at some numbers to see what is the efficacy. So this was a study published in 2016, which was a systematic review of about 26 studies of about 6,000 patients. And at the time of removal, which was about 6 months, the excess weight loss was about 36. Excess weight loss is basically your original weight loss minus your goal weight. There's a basic calculation for that. So pretty good. Other benefits, and most of the studies have shown similar sort of data, that about a third of patients you would see will have an improvement in their other comorbidities such as diabetes, hypertension, and hyperlipidemia. Adverse events, well, like anything else, balloons do have potential adverse events that we need to be aware of. Fortunately, the majority of them are minor to the point that they can be managed. Pain, nausea, and reflux are probably the most common and range between the 20 to 40% of patients will experience these side effects, usually in the first few weeks. But if you preempt that and use appropriate education as well as pharmacotherapy, you can manage those symptoms. Serious side effects such as small bowel obstruction, perforation of death are actually quite rare. So basically, the Obera intragastric balloon, the majority of the weight loss occurs in the first 3 months. However, the durability is questionable, and at about 2 to 3 year period, only about a quarter of the patients will maintain that weight. The thing being, it can be repeated if required. There are some important absolute contraindications, some relative contraindications that the proceduralist needs to be aware of and go through that list before going through with the procedure. So endoscopic sleeve gastroplasty, so this is sort of the new kid on the block, and the first studies have only come out in about 2015 in terms of published studies. So it's a technique whereby you reduce the gastric volume, similar in concept, or at least conceptually similar to sleeve gastrectomy, which the surgeons do. And basically it's an endoscopically placed full thickness sutures through the gastric wall, starting at the antrum and coming back to the cardia, and aiming to reduce the gastric volume by about 70%. There have been several devices which have been trialed, but the FDA approved device is the overstitch device by Apollo. And I will take you through some of those. So it is just some cartoons to show you what the stomach would look like before the procedure. This is intra-procedure. This is how those sutures are placed. And I'll show you a video of this too. And this is after the sleeve gastroplasty. So you can see the volume of the stomach significantly reduced. And so this is what it looks like at 3 months. Now again, I'm going to try and move this video along because this is just initially just a cartoon to quickly show what happens. You insert the endoscope and you use like an APC, argon plasma catheter, to make some markings along the anterior and posterior wall of the stomach, and these will act as guide for your suturing thing. And then you put these sutures in, and right, just move this. Sorry. So this is the same thing of the actual video slide. So the same APC catheter, which is, it's important to make these markings because once you start doing the suturing, there is going to be quite a lot of bleeding, as well as the constriction of the gastric volume. So it's quite easy to get disorientated within the stomach and lose vision, and you can get quite lost, and you may not get the desired results. So it's important to ensure that you've got those markings in place, and they act as landmarks. So this is the end of the device, which gets, it's an over-the-scope device, so you fix this at the end of your dual-channel gastroscope, and you can see that's the suture there. It's got a needle driver in that, and you'll see a needle come through as the video progresses. So this is passed through again through an over-tube into the stomach. And this accessory that you see here in the middle is called a helix, and what this does is it's got a screwing mechanism, and you drill this into the gastric mucosa because you want a full thickness suture. That means it has to go through the muscle, and if you did a laparoscopy, you should be able to see the suture outside the stomach. Only then will the suture last. If you don't get a full thickness suture, it's not going to last, and you won't get the desired effect. So basically, you do that screwing movement, you put it into the mucosa, you pull the mucosa through, and the needle driver goes through and takes a bite of the tissue. The procedure is a bit repetitive, but as you can see, those markings are important because you go in a triangular pattern initially. You go from the anterior wall to the greater curve and posterior wall. So it's a triangular motion, then you go back, and you take about 6 bites per suture. Like I said, it's a bit repetitive, so I can move this along a little bit. So there is some degree of bleeding that you will get with this procedure, and that's why going back to that marking bit is important. And then you end up with let's see. All right, so that's what the sleeve would look like if straight after the procedure. So as you can see, the volume of the stomach is significantly restricted. In terms of the data, once again, in the efficacy of this is probably the first pilot trial, which was published in 2015, of 20 patients who had a BMI between 30 and 35. And the excess weight loss was in the order of 48%. In this particular study, the author did not report any adverse events with the procedure. And then last year, this is the Abu Dhabi group from the Mayo Clinic, and they're one of the leaders in this particular technique. And they published this study on 25 patients and followed them up for about 20 months. And as you can see, the excess weight loss was in the order of between 45 and 55% during that period. There were 3 adverse events in this particular study, but all patients did recover fully. Spain is another big sort of center for endoscopic sleeve gastroplasties, and this study published last year of 248 patients followed up for 2 years, and they looked at the total body weight loss, which is different from excess body weight loss, and this was 18.6%, which is pretty good. And then one last study from Reem Saharia in the US, and they also followed up patients for 2 years with total body weight losses of 14, 17, and 30% respectively at those time periods. This study, they also looked at the metabolic profile, and there was a significant reduction in the HbA1c, systolic blood pressure, weight circumference, ALT, and serum triglyceride levels. So I think endoscopic sleeve gastroplasty is an effective endoscopic weight loss intervention. The mean total body weight loss ranges between 18 to 20% in different studies. The excess body weight loss ranges from about 30 to 50%. Most studies do show that there is a significant improvement in the patient's metabolic profile. It is durable, and if required can be repeated. Usually the whole procedure does not need to be repeated. Generally there's a stitch or a suture that might have come off, and you can go back and just resuture that part. It does have a reasonably good safety profile, at least in terms of serious side effects, although that data is still emerging. Very quickly, moving on to aspiration therapy just before dinner. I think the timing is perfect. This is somewhat controversial. Having said that, I was in the US a month ago, and it is being increasingly used. Basically, it involves putting in a wide bore peg tube into the stomach. And the patient is not really restricted in terms of how much they're going to eat. They eat, they're told to chew well, they drink lots of fluid, and an hour later they go to the toilet and they have a pump, and they basically pump it out. They justify it by saying that it's not punitive. So you're not telling the patients what to eat, how much to eat. Patients have a lot more control, and they can do it for as long as they want to. I don't know, but so this is what the gadget looks like, and they just have this pump. They go to the toilet and basically just pump out what they've just eaten. This on the left is what it looks like. So this hangs out outside like a peg tube, if anyone's seen a peg tube, and that's what's inside the stomach. The data is actually not too bad, and this is a multi-center study of 170 patients in the US, and there's demonstrated about 3 times weight loss compared to standard care. So 37% excess weight loss with significant reduction in the HbA1c and triglyceride levels. Now, I'm not going to talk about future therapies, except just to mention the endobarrier, which is a duodenal jejunal sleeve. And it was supposed to simulate the bypass procedure. It's sort of been in, out, and probably on the way back in, but we'll leave that for now. So in conclusion, I think, as the theme is, obesity is a growing epidemic. I think lifestyle modification along with pharmacotherapy remains the base of management. However, adjunctive therapy or therapies are often needed. Bariatric surgery is certainly an effective modality. However, I think it's time for endoluminal therapies to be included in the obesity treatment algorithm as an adjunct to lifestyle intervention and or pharmacotherapy. Endoluminal therapy should be particularly considered for patients who have either failed weight loss or weight maintenance with lifestyle therapy, possibly a primary therapy for patients with BMI between 30 and 40, or those with medical comorbidities that may require weight loss for additional bridging therapy. Patient selection is the key no matter what therapy you choose, and not one size doesn't fit all. But I think it's time to embrace the elephant. That's it for me. Yes.